A patient takes a routine daily medication to manage their blood pressure. Hours, or sometimes even years later, they present to the emergency department with life-threatening swelling of their lips and a rapidly closing airway. The immediate clinical instinct is to treat this as an allergic reaction to a new substance. However, this specific presentation often arises without any new environmental triggers, hiding in plain sight as a latent side effect of a long-term prescription. This reaction starts at the primary target of these medications, the angiotensin-converting enzyme, or ACE. To understand why the swelling happens, we have to look at ACE's second, frequently overlooked job. Inside your blood vessels, ACE acts as an enzyme called kinase 2. In a healthy baseline state, kinase 2 is constantly at work clearing out a potent inflammatory molecule called bradykinin. It snags the bradykinin and breaks it apart, keeping those inflammatory levels safely low. Think of ACE as a crucial regulatory janitor. By constantly sweeping up bradykinin, it prevents the dangerous buildup of vascular inflammatory signals. The sequence changes when a patient takes an ACE inhibitor, like Lisinopril. The drug enters the bloodstream and binds directly to the ACE enzyme to lower the patient's blood pressure. But there is immediate collateral damage to this blockade. By shutting down ACE, the medication completely stops kinase 2 from doing its secondary job. Without the janitor to clear the system, a molecular traffic jam occurs. Bradykinin rapidly accumulates in the bloodstream. Look at this side panel graph. It shows IgE and histamine levels remaining completely flat at their baseline, while bradykinin levels are spiking off the chart. Because this cascade is driven entirely by bradykinin, standard allergic mediators are unaffected, which means administering antihistamines will do absolutely nothing for this patient. The patient is experiencing a mechanical buildup of an inflammatory molecule caused by a severed degradation pathway. The immune system has not overreacted. As the overflowing bradykinin circulates, it seeks out and binds to specific B2 receptors located all along the endothelial wall of the blood vessel. This B2 activation triggers a dramatic physical response. The endothelial cells actively contract and pull away from one another. Pedagogical pause. Pause the video for a moment. Predict what will happen to the highly pressurized fluid flowing inside this vessel now that its walls have structural gaps. The clear plasma fluids aggressively leak, or extravasate, through the compromised microvascular wall, flooding into the surrounding interstitial tissue. This microscopic loss of endothelial integrity is the direct physical mechanism that shifts fluid out of the bloodstream and into the tissues of the body. Zooming out, we see how this microscopic extravasation translates directly into macroscopic soft tissue swelling, known as angioedema. The upper airway is uniquely dangerous. Its loose connective tissue acts like a sponge, leading to rapid expansion that physically chokes off the windpipe. Here is the 4-step sequence to remember. 1. ACE inhibition. 2. Bradykinin accumulation. 3. B2 receptor activation. And 4. Endothelial gap formation. Because this exact pathway is driven by the intrinsic mechanism of the medication itself, switching this patient to any other ACE inhibitor carries the exact same risk of airway obstruction. Understanding this molecular pathway allows you to differentiate between a standard allergy and a drug-induced emergency, ensuring you never administer the wrong treatment when seconds count.